Okay, good afternoon, guys. Yeah, you must be surprised to see a new face, right? So I just joined the department as senior resident, and so I'll be taking a few of your theory classes and your practical classes also. So I'll continue from the point where Dr. Biswajit sir had left, right? So let's just sum up a little bit. So by now you know the subdivisions of the lobules, all these things, and at this part you have to understand a little bit to know about how the cerebellum actually functions. So you have to understand that there are three layers. The outermost, which is the molecular layer, the second Purkinje cell layer, and third the inner granular layer. Okay, so the Purkinje cells are the most significant cells of the cerebellum. Okay, and these Purkinje cells, as you can see in this diagram, the cell bodies of the Purkinje cells, they form a single layer around the whole second layer of the cerebellum, right? So these cells, they form the second layer of the cerebellum. The dendrites of these Purkinje cells, they ramify. The meaning of the word ramify means it branches. It branches and rebranches within the first layer, which is the molecular layer. Okay, and in the molecular layer, you will find two more cells, basket cells and stellate cells. So these stellate cells, they actually lie horizontally, parallel to the surface of the cerebellum. And these fibers, they go, and axons, they will synapse with multiple Purkinje cells. So they form, these fibers, they go and form a kind of a basket around the cell body of the Purkinje cells. Not one, but multiple. Okay? And there is also another cell called stellate cells. So these stellate cells, they connect multiple branches coming from different Purkinje cells, and they connect them with each other. So coming to the third layer, this is also called the inner granular layer. So here you will again find two types of cells, the granule cells and the Golgi cells. So the granule cells gives the name granular cell layer to this layer. And as you can see, the granule cells, their fibers in this diagram, this is the red color if you can see this. So this fiber, it rises up towards the other two layers. And in the first layer, that is in the outer molecular layer, it again branches and forms a parallel connection between the different granule cells. It forms a parallel connection in the first layer. Okay, and they again connect the different Purkinje cells with each other. Another type of cell is the Golgi cell. The Golgi cell is also found in the inner granular layer. And this inner granular layer, the Golgi cells, they again connect to different Purkinje cells in the second layer. And also it participates in the formation of something called a glomerulus. So a glomerulus is actually a meeting point of three different fibers, and in this glomerulus, here you can see we have an enlarged image of the glomerulus is present. So to understand the glomerulus, you have to understand what are the fibers that enter into the cerebellum. Okay, so the two types of fibers enter into the cerebellum, which is one is the climbing fiber. This you can see, right? This is the climbing fiber, and another type of fiber is the mossy fiber. Okay, so two types of fibers enter into the cerebellum as afferent connections. Afferent, okay, not efferent. Efferent is going away from. Afferent means coming towards, right? So this climbing fibers, it enters into the cerebellum and it directly goes and synapses with a Purkinje cell. Although the Purkinje cell is present in the second layer, this connection between the climbing fiber and the Purkinje cell occurs in the first layer because the dendrites of the Purkinje cells, they are present in the first layer. So this is the climbing fiber. The other type is the mossy fiber. So the mossy fibers also stimulates the Purkinje cells, but indirectly. How? These mossy fibers does not directly go to the Purkinje cells, unlike the climbing fiber. These mossy fibers first synapses with a granule cell, and this granule cell, it will go and synapse with the Purkinje cells. Okay, so ultimately both these fibers, they will go to the they are responsible for the stimulation of the Purkinje cell, but climbing fibers do it directly, while the mossy fibers do it indirectly via the intermediary cell, which is the granule cell. So this mossy fiber and the granule cell, together with the Golgi cell, it participates in the formation of something called glomerulus. So the mossy fiber, actually it divides and redivides the axon of the mossy fiber. This mossy fiber, it divides and enlarges to form something called rosettes. Okay, these terminal enlargements. If you remember the general structure of an axon in a structure of a nerve cell, there was something called the terminal knob, if you remember. So something like that, and these enlargement and enlarged swellings at the end of the mossy fiber, they are called rosettes. These rosettes in the mossy fiber, connect with a dendrite of a granule cell and an axon of a Golgi cell. Okay, and these three structures together, it forms something called a glomerulus. And these entire connections, these three structures which come together at this point, it is surrounded by neuroglial cells. So together, these three structures surrounded by neuroglial cells, it is called the glomerulus of the cerebellum. And what are the three components of the glomerulus of the cerebellum? It is the terminal ending or the rosettes of the mossy fiber, the dendrites of the granule cells, and the axons of the Golgi cells. Okay, so this is the meeting point of these three structures. And here, as you can see, the five cells, important cells present in the cerebellum are the basket cells, stellate cells, Purkinje cells, granule cells, and Golgi cells. Now, among all the cells in the cerebellum, only the granule cells are excitatory cells. All the other cells are inhibitory cells. You see, as the mossy fiber comes and stimulates the granule cells, it acts as an excitatory cell for the Purkinje cells. Okay, so all the cells present within the cerebellum, they are inhibitory cells except the granule cells, which is an excitatory cell. Okay, so now here what they have shown is the neuron in the cerebellar cortex, which is and the organization into the three layers. So the same thing which we were discussing here has been shown here a little bit more schematically. Okay, and here on the diagram on the right side, you can see the different connections. So how the deep cerebellar nuclei neuron is stimulated by the Purkinje cells. Okay, now this will come to it a little bit later. What is the deep cerebellar neuron? I think you know that there are certain nuclei present embedded within the white matter of the cerebellum, and these are called the deep cerebellar neurons. And these deep cerebellar neurons, they form the major output or the efferent fibers of the cerebellum, and these nuclei, they are actually stimulated by the Purkinje cells. Purkinje cells are again stimulated by what? Climbing fibers, and indirectly by the mossy fibers via the granule cells. You remember? Also, they are connected to each other again by the basket cells. So these are all the cells which stimulate the Purkinje cells, but they are inhibitory. So we'll come to this a little bit later. Just remember the cells and what are the inputs and the outputs from the cerebellum. Okay, so the cells are five. The inputs are climbing fiber and the mossy fiber, and the outputs are mainly via the Purkinje cells through the deep cerebellar nuclei neurons. Okay, we'll come to this. So this is the connection or the circuit which is present within the body of the cerebellum. Okay, before that, what are the cerebellar nuclei actually? Okay, so we'll come to the cerebellar nuclei after some time. Okay, so these are the cerebellar nuclei. The dentate, globose, emboliform, and fastigial. These are called the cerebellar nuclei. And you have to understand the cerebellar nuclei to understand the outputs of the cerebellum. Okay, so dentate, globose, emboliform, and fastigial. This the cerebellum is divided into three parts: neocerebellum, archicerebellum, paleocerebellum. Remember? That was the most initial concept of the cerebellum. Okay, archicerebellum is which is the oldest part of the cerebellum, sends the signals to the fastigial nucleus. Paleocerebellum, which is a little bit more modern from the evolutionary point of view, sends their connection to the globose and emboliform nucleus. While the neocerebellum, which is the most evolutionarily advanced part of the cerebellum, sends their connections to the dentate nucleus. Okay, and from these nuclei, the major output of the cerebellum, it comes out. So ultimately, from the Purkinje cell layer, the axons of the Purkinje cells, this one. See, these axons of the Purkinje cells, they carry the signals away from these three layers of the cerebellar cortex, and ultimately they will go and stimulate those neurons. Okay, and these neurons present in the deep cerebellar nuclei, and these connections in the deep cerebellar nuclei, they will send the outputs from the cerebellum. Okay, so majority of the outputs of the cerebellum, they go from this deep cerebellar nuclei, except a few fibers from this part, flocculonodular lobe and the vermis. Okay, so they travel directly out of the cerebellum without any connection in the deep cerebellar nucleus. Okay, now to understand this circuitry, you have to remember that the climbing fiber and the mossy fibers, they are excitatory. Okay, what are the climbing and mossy fibers? The climbing fibers and mossy fibers, they are the inputs or the efferent fibers that enter into the cerebellum. These climbing fibers, they go and stimulate the Purkinje cell directly, while the mossy fibers, they first stimulate the granule cell, and these granule cells, will go and stimulate the Purkinje cell. Right? Now these are excitatory fibers. Mossy fibers will go and stimulate the granule cell, and I told you granule cell is the only excitatory cell present in the cerebellum. Right? So the mossy fiber stimulates the granule cell, and the granule cell will excite the Purkinje cell. Climbing fibers will excite the Purkinje cell directly. Okay, now you see these Purkinje cells, they also receive connections from the basket and the stellate cells. However, these are inhibitory. And connections from the granule cell to the Purkinje cells, they send collaterals to the Golgi cells, and they send collateral to the basket and the stellate cells also. However, they are inhibitory. Okay. Now these granule cells in turn again receives connections from the Golgi cells, which are again inhibitory in nature. Now this output from the Purkinje cells which go to the deep cerebellar nucleus, this is also inhibitory in nature. Okay, and the deep cerebellar nucleus which sends the final efferent fibers coming out of the cerebellum, they are excitatory in nature. Okay, so what you have to understand is that the more a Purkinje cell is stimulated, the less will be the strength of the output from the cerebellum. Okay, the strength of the output from the Purkinje cell. And since the Purkinje cell is inhibitory, if its strength of the output decreases, then the strength of the output from the central nucleus, it will increase because the inhibition will decrease from the Purkinje cell. Okay, so that's what you have to understand. So if a stronger signal enters into the cerebellum, the Purkinje cell will be stimulated. If the Purkinje cell is stimulated more, it will inhibit the central nucleus more, and if the central nucleus is inhibited more, the signal coming out of the cerebellum will have a less strength. Okay, which is an excitatory stimulus. So excitatory stimulus getting lesser strength, that means the final output from the cerebellum will have a decreased strength. So it is kind of like, you know, a fine tuning circuitry which is going on within the body of the cerebellum. Okay, and this fine tuning circuitry within the cerebellum, it ultimately leads to smoothing out of your movements. I'll talk about that. Something called a comparator function. Just remember the word comparator function, and I'll talk about it. Okay, so let's come to the cerebellar peduncles now. Now, what are peduncles? Okay, so these cerebellar peduncles, the word peduncles means actually pillar. Okay, so these are literal meaning of the word peduncle is pillar. Okay, so these cerebellar peduncles, there are three pillar-like connections by which the cerebellum is connected to the brainstem. Okay, so there are three pillar-like connection or three cerebellar peduncles: the superior cerebellar peduncle, the middle cerebellar peduncle, and the inferior cerebellar peduncle. Okay, now this superior cerebellar peduncle is also called brachium conjunctivum. Okay, the middle cerebellar peduncle is also called brachium pontis, and the inferior cerebellar peduncle is also called the restiform body. The superior cerebellar peduncle connects the cerebellum to the midbrain. The middle cerebellar peduncle connects the cerebellum to the pons, and the inferior cerebellar peduncle, it connects the cerebellum to the medulla. Okay, so these are the three connections of the cerebellum to the brainstem. From the midbrain, one connection comes, and remember these are bilateral, that is one on each side. There are two superior cerebellar peduncles, one on either side, two middle cerebellar peduncles, one on either side, and two inferior cerebellar peduncles, one on either side. So first let's come to the superior cerebellar peduncle. As I told you, it connects the cerebellum to the midbrain. Okay, so remember that the superior cerebellar peduncle, it forms the main fibers present in the superior cerebellar peduncle. They are efferent fibers from the cerebellum. Okay, however, there are some afferent fibers, but most of the fibers are efferent fibers. Okay, so what are the efferent fibers? That is the dentorubral and the dentothalamic tract. Dentatorubral and the dentatothalamic tract. Dentato means it comes from the dentate nucleus. I told you about this, the cerebellar nucleus, the dentate, globose, emboliform, and fastigial. Remember? So the dentate nucleus, it sends its connection from the superior cerebellar peduncle. This is the dentatorubral tract which goes to the red nucleus, and the dentatothalamic tract which goes to the thalamus. Okay, and it communicates with the motor cortex via the midbrain and the thalamus. Then you have the cerebellorubral fibers. This goes from the nucleus interpositus to the rubrospinal tract and facilitate flexor muscle tone. So where is the nucleus interpositus actually? Okay, I didn't say about the nucleus interpositus. Just remember that the globose and the emboliform nucleus together, they are called the nucleus interpositus. Okay, so from the nucleus interpositors, that is from the globose and the emboliform nucleus, these fibers, they go to the via the rubrospinal tract, and it facilitates the flexor muscle tone. Okay, now there is the cerebello-olivary nucleus, where the fibers, they come from the dentate nucleus up to the olives. Okay, and there is also the cerebello-reticular fibers, where the efferent fibers from the cerebellum, from the dentate nucleus, of course, they goes to the reticular formation. Okay, so these are the efferent fibers present in the superior peduncles. Now, what are the efferent fibers? That means fibers which enter into the cerebellum from the superior peduncles. They are the anterior spinocerebellar tract from the spinal cord, tectocerebellar, trigeminocerebellar tract, which comes from the tectus and the trigeminal nuclei of the spinal cord. The trigeminal nuclei, trigeminal cranial nerve nuclei, and there is also the cerebellar tract. Okay, it comes from the cerebellum up to the cerebellum. So these are the major efferents or the inputs into the cerebellum via the superior peduncles. Next, let's come to the middle cerebellar peduncle. So middle cerebellar peduncle comes from the pons, and from the pons, only efferent fibers enter into the cerebellum via the middle cerebellar peduncles. Okay, and it receives informations advising it of voluntary motor activity initiated by the motor cortex. That means any voluntary motor activity that initiates in the cerebral cortex, while it goes down to the target organ, it also gives a signal to the cerebellum via the pontine nuclei, so that the cerebellum can get an idea of what is the intended movement and then smoothen it out. Okay, so a little bit complex, but you have to try to understand. Okay, so this is the cortico-ponto-cerebellar pathway. That means from the cortex to the pontine nuclei, and from the pontine nuclei to the cerebellum. Okay, so ultimately it is a signal which originates from the cerebral cortex, and the motive of this signal entering into the cerebellum is to smoothen out the voluntary motor activity. Okay, and the other fibers are the reticulocerebellar fibers. That means it originates from the reticular formation to enter into the cerebellum. Okay, so the middle cerebellar peduncle contains only efferent fibers. Okay, fibers which only enter into the cerebellum. Coming to the efferent peduncle, inferior peduncles. So the inferior cerebellar peduncles contain the efferent fibers of the cerebellum, which goes from the cerebellum to the vestibular nucleus, to the reticular formation, and the olivary nucleus. That means cerebellovestibular pathway, cerebelloreticular pathway, and the cerebello-olivary pathway. Okay, and the efferents. So these efferents, they are conveying sensory information from the muscle. Efferents, that means the fibers which are coming into the cerebellum. They carry proprioception. Proprioception is joint position sense. Okay, so these fibers, they carry the proprioception from the body, and also from the vestibular nuclei of the brainstem. Okay, so from the different joints of the body, these fibers, they carry the proprioceptive signals, and also from the vestibular nucleus of the brainstem and spinal cord. Okay, and these fibers are the posterior spinocerebellar pathway. That means it comes from the spinal cord. Vestibulocerebellar pathway, that means the signals that comes from the vestibular nucleus. Olivocerebellar pathway, and the parolivocerebellar and reticulocerebellar pathway. Okay, olivocerebellar pathway originates from the olivary nucleus. Parolivocerebellar is the parolivary nucleus, and the reticulocerebellar pathway is from the reticular formation to the cerebellum. So these are the efferents. This part I have already given you a little bit of idea that what are the nuclei. These are the dentate nucleus, nucleus interpositors, and vestigial nucleus. Okay, the interpositors, I told you, this means globose and emboliform together. Okay, nucleus globose and nucleus emboliform together, they are called nucleus interpositors. Okay, here you can see the signals from the cerebellar cortex. That means the cerebellar cortex means what is the major output from the cerebellar cortex? I mean, the only output is from the Purkinje cells. From the Purkinje cells, these cells will come and they will stimulate the cerebellar nuclei, dentate, globose and emboliform, and vestigials. And from these, the signals, they will exit. It will go into different parts, like the ventrolateral nucleus, a red nucleus. Okay, so again, from these nucleus, for example, if from the red nucleus, again fibers will go to the spinal cord, right? So this becomes the rubrospinal tract. Okay, so these are the major outputs from the cerebellum. If I first talk about the dentate nucleus, say this is the dentate nucleus, I marked in red. It projects contralaterally. That means the outputs from the dentate nucleus, it goes to the opposite sides of the body. From where it goes? It goes through the superior cerebellar peduncle. And its target is what? It goes to the thalamus. And from the thalamus, these fibers, they go to the cerebral cortex. Where? Into the motor cortex. Okay? And what is the function? Its function is to influence the planning and the initiation of the voluntary movement. So any voluntary movement that you want, for example, lifting up your hand, writing, okay? So all these gross motor and fine motor functions, its initiation should be smooth. It cannot begin with a jerk, okay? So this is the function of the dentate nucleus. Ultimately, this is the function of the cerebellum as a whole. Emboliform and globose nuclei, they project mainly to the contralateral red nucleus. And from the red nucleus, okay, a small part is projected to the motor cortex. Mainly from the red nucleus, the rubrospinal tracts, they appear. And from the rubrospinal tract, it controls the proximal limb muscles. That means the upper limb muscles. Then let's come to the vestigial nucleus. Vestigial nucleus project to the vestibular nucleus and to the pontine nucleus and the medullary reticular formation. Okay, vestigial nucleus project to the vestibular nucleus, to the pons, and to the reticular formation in the medulla. So these fibers are the vestibulospinal and the reticular spinal tracts. So to understand this, you have to first understand three things. First, you have to understand evolution. Second, you have to understand which parts of the cerebellum is developmentally more recent and which parts of the cerebellum are late. Are earlier in their developmental history. And thirdly, you have to correlate that with the nucleus, which is the nucleus of the older parts of the cerebellum and which is the nucleus responsible for the newer or more modern parts of the cerebellum. And along with that, you have to remember one thing: which functions of the body are evolutionarily older and which functions of the body are evolutionarily recent. Okay, for example, standing upright is an evolutionary much older skill compared to writing or painting or playing a musical instruments, all these things. Okay, so if a movement is more modern from the evolutionary point of view, then it will be a function which is coordinated by the neocerebellum. Standing upright is one of the most ancient skills that have been developed from the evolutionary point of view. So that will be under control of the oldest part of the cerebellum, which is the archicerebellum. And it will be under the control of the vestigial nucleus, because the vestigial nucleus is ultimately the nucleus of the archicerebellum. Okay, so that is why the vestigial nucleus, it sends signals to the vestibular nucleus and to the reticular formation, because it is the vestibular nucleus and reticular formation, etc., which is mainly responsible for keeping you alert and upright. Okay, again, dentate nucleus, it projects for voluntary movement because these are more skilled and these are the functions of the neocerebellum. And compared to both these functions, emboliform and globose, they project mainly to the spinal cord, because gross movements of the upper limbs, they are a little bit more recent than standing upright, but it is ancient compared to fine motor skills. Okay, so these are the things that you have to relate and remember while understanding the functions of the cerebellum. So let's come to the arterial supply. So you just remember that the arterial supply of the cerebellum is from three major arteries, of course one on either side for each hemisphere. So a pair of superior cerebellar arteries which appear from the basilar artery. And where is the basilar artery? Basilar artery is present in the anterior part of the pons, right? So it's a pair of superior cerebellar artery. Then again there is a pair of anterior inferior cerebellar artery, and this anterior inferior cerebellar artery is again a branch of the basilar artery. Okay, and there is another pair of artery called the posterior inferior cerebellar artery, and this posterior inferior cerebellar artery is a branch of the vertebral artery, just before the vertebral arteries unite to form the basilar artery. Okay, so three sets of arteries: the superior cerebellar artery, the anterior inferior cerebellar artery, and the posterior inferior cerebellar arteries. Okay, so this forms the major arterial supply of the cerebellum. Okay, Now let's come to something called the cerebellar disorders. So these cerebellar disorders, that means problems which occur in the disorders of the cerebellum, this is called cerebellar syndrome. So cerebellar syndrome, here you remember truncal ataxia and staggering gait. What is truncal ataxia and staggering gait? So in truncal ataxia and staggering gait, the person is not able to maintain their upright posture, and staggering gait means when the person is trying to walk. Okay, when the person is trying to walk, then the gait does not occur as a normal gait. It appears to be disturbed. It's a staggering gait. The person tries to initiate their foot movements, leg movements, and then they fail. So they stagger in front. It's as if they are trying, as if they might fall down. So so this is called the staggering gait. Nystagmus. It should be nystagmus. Okay, Nystagmus. Nystagmus. Nystagmus is a rapid involuntary movement of the eye. So normally our eyes, if we fix it at a particular point, even if we are unconscious about it, the eye does not deviate from that point. So if you remain fixed, you can fix your gaze at one point, the eyeballs remain fixed. But in nystagmus, what happens? The eyeballs, they move involuntarily, without the control of the person, and the person cannot control that rapid side to side or to and from or up and down movement of the eye. So this is called nystagmus. Okay, and what you have, you can remember is the truncal ataxia, staggering gait, and nystagmus. These occur due to the abnormalities present in the archicerebellum. Okay, in the oldest part of the cerebellum, that means, like I told you, standing up straight. Okay, and then maintaining your gait or maintaining your gaze. This is a function of the archicerebellum. These are some of the oldest skills that the human body has developed from the evolutionary point of view. So this is from the abnormality in the archicerebellum. And Romberg sign positive. What is Romberg sign? It is the same. This Romberg sign positive gives an indication of truncal ataxia. So what is Romberg sign? So if you ask the person to fold their hands across their chest and close their eyes while standing up straight, the person won't be able to maintain their erect posture, and they might fall down. Okay, and they might, it's called Romberg sign positive. So Romberg sign positive is an indication that there is some kind of cerebellar disorder wherein the person is not able to maintain their upright posture. So this is called truncal ataxia. So it's a Romberg sign is an indication of the truncal ataxia. It also gives you a degree or the extent to what extent the truncal ataxia is occurring. Like if the person closes their eyes and immediately they fall down, then this is a more severe disorder than if the person is closing their eyes and just finding it difficulty to maintain their upright posture, and after some time they fall down. Okay, so by how quick the truncal ataxia develops, this also gives an indication of the severity of the cerebellar disorder or the cerebellar syndrome. Then there is hypotonia. Hypotonia, as you know, hypotonia is the decrease in the muscle tone in the skeletal muscle, and it happens in the affected side of the body. Okay, so if the left side of the cerebellum is damaged, then the left side of the body will have hypotonia or decreased muscle tone. Okay, and this results as a result of decreased supraspinal facilitation. What is supraspinal facilitation? So there is muscle tone. That means even if you are not contracting a muscle, even if the muscle is relaxed, there is an inherent tone. The muscle is always in a very small, and particularly the limb muscles, they are present in a very slight state of contraction. This is called the tone. So if the supraspinal facilitation from the cerebellum, that means the signal from the cerebellum is lost, then the muscle tone, it decreases, and because of decreased muscle tone you will find hyporeflexia. That means the reflexes won't be exerted normally. So for example, the knee jerk, the bicep jerk, different tendon jerks, the reflexes, the strength of the reflexes, this will decrease. This is called hyporeflexia. Then there is something called dysmetria. These are errors in the range and direction of movement. So there is something called the finger nose test. And if the finger nose test is positive, then we say that the patient has got past pointing. So dysmetria, it means, now if a normal person is asked to close their eyes and touch their nose, normally they are able to do it. So dysmetria is like so those small very insignificant but important movements which we don't think about. If you are asked to, if a person with a cerebellar disorder is asked to perform them, they are not usually able to perform these things. That means the position of different organs and different parts of the body, different position of joints, and these signals that come from the proprioception of different joints, it becomes very, they get damaged. And because of this, the person is not able to carry out these simple functions. So if they are asked to close their eyes and touch the tip of their nose, they usually miss it, and then their fingers moves against the side of their face, way past their nose. So this is called dysmetria. So this is also an indication of cerebellar disorder. Then there is intention tremor or kinetic tremor. That means when a person is trying to perform something, trying to perform a function, and for example any crude movement like lifting up a book or hammer, or lifting up a water bottle, or even fine skills like maybe playing a musical instrument, trying to paint, trying to write, okay? Because of the problems with the cerebellar signals, the movement becomes rough. The smoothing of the movement is absent. So that is why the person gets intention tremor. That means when a person is trying to perform some task, the tremor occurs. Okay, there's something called rebound phenomena. Okay, rebound phenomenon is a test where the person is not able to check their movements. Okay, for example, if a person is told to apply resistance against the hand, and the doctor, suppose this is the doctor's hand, and they are trying to force their hands against each other. Normally what happens, if the doctor removes their hand, this hand before hitting the face, the person can check their movements. Okay, and this is in cerebellar disorders, this is absent. So what happens when the doctor, as soon as the doctor removes their hand, the person will hit against their own face. So that checking of movement is absent. So this is called rebound phenomenon. Then there is something called Diadocokinesia. This Diadocokinesia means rapid movements. For example, rapid pronation, supination, or voluntarily doing inversion and eversion of the foot, or rapid side-to-side movement, turning of the body. So rapid movements or rapid alternate movements in different parts of the body, they becomes incoordinated with each other. So this is called the Diadocokinesia. And then again there is dysarthria or scanning speech. That means the person is willing to say something, but they won't be able to articulate properly. Okay, they will go into a long blabbering, monologue, which will mostly be incoordinated. There will be pauses in different inappropriate places, or the pause which is not required. Sometimes the person might talk too fast, or sometimes the space between words, they will be obviously abnormal. So this is called dysarthria or scanning speech. Okay. Now this hypotonia, dysmetria, intention tremor, all this, mainly hypotonia and dysmetria, this occurs due to abnormality in the paleo-cerebellum. Remember, truncal ataxia, staggering gate, nystagmus was an abnormality of the archicerebellum. Hypotonia, dysmetria, these are more indications of abnormality present in the paleo-cerebellum, while this rebound phenomena, this Diadocokinesia and dysarthria, these are this mainly occurs due to abnormalities in the neocerebellum. Okay, so this is more about the cerebellar disorders. Now, I told you one thing, that there is something called the comparator function of the cerebellum. Now, I don't have a slide for that, but just I will try to tell you what is that. So the comparator function of the cerebellum is that cerebellum is the center where there is a comparison between the intended movement and the movement which is being carried out. Okay, so what is that? That means any voluntary movement, the initiation of the voluntary movement will take place in the cerebral cortex. Suppose you want to point your finger in any direction, right? So that initiation of the movement starts in the cerebral cortex. So as the signal from the cerebral cortex goes down into your muscles to carry out that movement, it also sends a signal to the cerebellum. This is the movement I want to carry out. And the cerebellum takes that signal from the cerebral cortex, and now the cerebellum knows what is the movement that has to be carried out. Now the cerebellum also receives signal from different joints, proprioception, different position of joints. Okay, so these afferent signals into the cerebellum from these different body parts, the proprioception, they send a signal to the cerebellum to tell the cerebellum that what is the movement that is being carried out. So the cerebellum now has two sets of data. One set of data from the cerebral cortex, which tells the cerebellum what is the movement that has to be performed, and one set of data from the muscles, the joints, etc., which tells the cerebellum what is the movement that is actually being carried out. Now within the cerebellum, there is a comparison between these two sets of data. And using that internal circuitry that we talked about, remember this internal circuitry of the cerebellum, this adjusts any differences. For example, if the cerebellum senses that there is any kind of discrepancy, that the internal movement is not being carried out, then immediately this internal circuitry of the cerebellum, it comes into force, and then by repeated smoothing action, the signal again goes back to the muscles and joints that no, this is not being carried out, you have to perform it more smoothly, or you have to exert more force or more pressure. So this is all being done involuntarily within the cerebellum itself. So the cerebellum maintains this the equality between the intended movement and the actual movement. So as long as the cerebellum is functioning properly, the intended movement becomes equal to the movement which is being carried out. That is, the intended movement and the actual movement is almost the same. So for example, if my intended movement is to pick up this phone, then when I pick up this phone, that means my intended movement and my actual movement is equal, and because of this, I can say that more or less my cerebellum is functioning very well. So this is the comparator function of the cerebellum, so to speak. Okay, so we have come through all this, and let's look at these images for a minute. Okay, so the first picture what they are showing is the finger nose test. Okay, so in the finger nose test, when the patient is asked to touch the tip of their nose, the patient is able. Okay. Second, here what we are seeing is staggering gait. This picture, the person who is trying to walk, this is a staggering gait. In the staggering gait, you see the movement is not smooth. That means here the person wants to walk, which is the intended movement, but the person is not able to walk like the way he wants to. So that means the actual movement is different. So cerebellum is not able to equalize the intended and the actual movement. That means there is a cerebellar disorder. And this photo in the middle, it shows this one, rebound phenomenon. The person is asked to give force against the doctor's hand, and immediately as the doctor or the person who is conducting the test leaves the hand, his own hand will hit his face. So he's not able to check his movement. Then these eyes is just showing nystagmus, so it will be rapid movement. See, we can voluntarily look on either side. This eye movement can be done voluntarily, right? We can look this side, again we can look the other side. But in nystagmus, this occurs involuntarily. You are trying to look in a particular direction, but the eyes keep moving to and fro like this. Okay, so this is nystagmus. And here we can see, last image, this is the intention tremor. The person might be trying to, touch the tip of their fingers together, but it's not happening because the hand is repeatedly in a state of tremor. Okay, so touching the two fingers with each other is very difficult for such person. Now, sorry. One thing you have to pay attention to is that this coordination and smoothing of the voluntary activities is a function of two parts of the central nervous system, cerebellum as well as the basal ganglia. What we have to remember is that in cerebellar disorders, these tremors, they occur while performing the movement. That means intention tremor. While in basal ganglia disorders, these tremors occur while the person is at rest. That means resting tremor. Okay, in basal ganglia disorders, there is resting tremor, while in cerebellar disorders, there is intention tremors. So basically, this is all about cerebellum, and I hope I have been able to teach you something. So we'll meet hopefully soon, and we'll get to know each other, right? Okay, that's it. Thank you.